Thank you for that kind introduction, and thank you to AACR for allowing me to present our work here today. I'm honored to represent our study group from Baylor College of Medicine, which is led by Dr. Meenakshi Hegde. And today I'll review the results from our ongoing phase 1 clinical trial testing HER2 CAR T-cells in combination with lymphodepletion chemotherapy for patients with advanced sarcomas. I have no disclosures to report. So HER2 is a protein in the epidermal growth factor receptor family, and unlike its family counterparts, it has very limited natural expression in the body. It is aberrantly expressed on the surface of cancer cells in a variety of tumors. By pairing it with itself or with one of its partners in a tumor cell, it can activate signaling pathways that promote cancer cell growth and survival. HER2 can be expressed in a variety of sarcomas, including osteosarcoma, the most common malignant bone tumor, where HER2 expression has been correlated with worse survival. However, unlike HER2-positive breast cancers, the amount of HER2 present on the surface of sarcomas is much less, as you can see here by the HER2 staining in brown. This lower level of expression is not sufficient for HER2-targeting drugs such as trastuzumab to have efficacy. We developed a HER2-specific chimeric antigen receptor molecule made up of a HER2 binding domain from an FRP5-derived antibody connected with the signaling domain of a T-cell containing CD28 co-stimulation. We treated patients in an adoptive approach by isolating T-cells from their blood, retrovirally transferring our HER2 CAR T-cell in our GMP facility, and then infusing them back into the patients in combination with lymphodepletion chemotherapy. Our patients were treated in 2 dose levels, 9A and 9B, with the previously highest cell dose tested without lymphodepletion. 3 patients were treated on dose level 9A with 5 days of fludarabine preceding CAR T-cell infusion. 8 patients have been treated on dose level 9B with cyclophosphamide over 2 days, fludarabine over 5 days, followed by CAR T-cells. Patients were followed for a safety period of 6 weeks, at which point repeat disease evaluations were performed. Patients with stable disease or responsive disease were eligible to receive additional CAR T-cell infusions. Of the 11 patients treated in this lymphodepletion cohort of the trial, 5 had metastatic osteosarcoma. All 5 had failed prior salvage treatments, including surgical resections, and 4 out of 5 had received 1 or more investigational agents. Of the remaining patients, 1 had synovial sarcoma, 3 had alveolar rhabdomyosarcoma, and 1 had Ewing sarcoma. Patient 5 with rhabdomyosarcoma was treated and later re-enrolled as patient 7. Again, they were all heavily pretreated. We observed significantly improved expansion of our HER2 CAR T-cells at 1 week post-infusion in both lymphodepletion groups compared to the same dose level tested without lymphodepletion. Despite this improved expansion, we observed no dose-limiting toxicities. We did observe expected grade 4 drops in their blood counts, though no patients required transfusions and no patients developed opportunistic infections. There were no serious cardiac or pulmonary toxicities observed, and all patients maintained normal heart function throughout the study period and in longer-term follow-up. I note this as patients receiving other HER2-directed therapies, such as trastuzumab, are at risk for decreased heart function. Our patients developed a maximum of grade 2 cytokine release syndrome, which resolved within 5 days of onset with supportive care alone, and there were no neurologic toxicities observed. All patients were evaluable for response, and all patients had active metastatic disease at the time of treatment, with the exception of patient 6, a 16-year-old girl with multiply recurrent osteosarcoma. At the time of treatment on study, she was in her 3rd relapse and had undergone resection of a 10-centimeter lung metastasis with resulting positive surgical margins. Due to her high risk for tumor progression, permission was granted by the FDA to infuse her with CAR T-cells despite her lack of measurable disease. She remains alive without recurrence at 34 months post-treatment. Another patient, patient 5, whom I will describe more in a moment, was an 8-year-old boy with rhabdomyosarcoma who achieved a complete response after CAR T-cells, which was maintained for 12 months. Upon relapse, he was re-enrolled and treated as patient 7, and again achieved a complete response, which has been ongoing for 17 months. 4 patients had progressive disease at the end of the initial 6-week period, and 4 patients had stable disease lasting for 3.4 to 9 months. 5 of 10 patients are alive at last follow-up, and overall survival for all patients treated with lymphodepletion was approximately 60% at 1 year. Now I will briefly highlight one of these patients. Patient 5, as I described earlier, had metastatic rhabdomyosarcoma to the bone marrow, as shown here in the upper panel. We enrolled him, and following his third CAR T-cell infusion, we observed remission of his cancer. Because of his response, we investigated further studies of his immune system to better understand mechanisms for this response. Following each HER2 CAR T-cell infusion, we observed the appearance of new T-cell clones which were not present prior to treatment. We do not yet know the specificity of these clones, and we are actively working to determine this. When we screened the patient's serum for antibody responses against a large number of known human proteins, we identified new antibodies after treatment, the majority of which were directed against non-HER2 intracellular proteins, as shown here in yellow. Many of these proteins are interconnected with pathways, shown here in red, that are associated with promotion of cell proliferation, survival, and tumor metastasis. These findings suggest that the patient's own immune system may be engaged to elicit new immune responses after treatment with HER2 CAR T-cells and lymphodepletion chemotherapy. So in summary, HER2 CAR T-cells can be safely given in combination with lymphodepletion. Lymphodepletion enhances T-cell expansion and persistence. HER2 CAR T-cells can induce objective clinical responses in some patients with sarcoma. An engagement of endogenous immunity may aid in the generation of tumor responses, and we are currently working to validate these findings in other patients who are treated. Finally, I would like to acknowledge the patients and families who participated in this trial. My mentors, Dr. Hegde and Dr. Ahmed. Dr. Hegde was critical in the design of this trial and in the immune correlative studies I presented. And Dr. Ahmed and Dr. Godschak were involved in designing the initial clinical trial testing HER2 CAR T-cells without lymphodepletion. I'd like to thank all the other members who have been involved in this study and our leadership, as well as our funding sources, and I'd be happy to take any questions at this time.